The GI division here at UMass is changing, like much of healthcare in the United States is changing. And as I see it in the future, what's going to happen is that the things that we do will become even more subspecialized. And so we're trying here to develop some of the newer techniques, and particularly we've emphasized some technical aspects of the things that we do, and we've put a very strong emphasis on developing new types of procedures, new types of equipment that we think will help to push our profession to new heights. One of the things specifically that we're interested in is studying the small bowel. 20 years ago, the small bowel was a 20-foot GI organ that we knew about but couldn't see. We could only see it with an X-ray.
We do get all sorts of things occurring in the small bowel. It's a site of what we call obscure bleeding, little superficial blood vessels that bleed intermittently but can require a lot of blood transfusion.
About 10 years ago, the pill camera was invented, and with that we could see the images in the small bowel. So this 20-foot structure that we couldn't see for many years, we suddenly were able to visualize.
The pill cam allows us to do things that really weren't possible pre-2001. We had to rely, we did have CAT scans, we did have barium studies which allowed for visualization in rather primitive terms of what was going on in the small bowel. We could look for Crohn's disease, we could look for polyps. You couldn't really see where bleeding was coming from. So the pill cam allowed us to start to see these sites where bleeding was coming from.
I think that we've been at the cutting edge in terms of developing and understanding new devices to image the small bowel, and then as an offshoot of that and sort of a logical progression, we've tried to be on the cutting edge in developing new instruments for treatment of those diseases.
We have 3 different types of enteroscopes, which all basically do the same thing. They're long scopes fitted with overtubes, and by various devices on those overtubes, you can concertina the intestine back over the scope. So instead of pushing and getting loops, we can pull in a concertinaed fashion the intestine back and get much, much deeper into the small intestine.
You know, some of the things that we do here that I think is unique, especially in the population of patients who have obscure GI bleeding, of which a lot of them are in the small intestine. We're very aggressive with the video capsule endoscopy, and often finding bleeding in the small bowel fairly quickly, and then we have set up kind of mechanisms that we could, one of us, either myself, Dr. Cave or Dr. Bhattacharya, can go ahead and do either a deep enteroscopy, anterograde, or do a retrograde deep enteroscopy in order to try to fix that bleeding.
Endoscopy is used in patients who have gastrointestinal bleeding, for example, to help us localize. We work very closely with our gastroenterology colleagues to try to localize where is the bleeding coming from. Is it coming from the upper portion of the gastrointestinal tract? Is it coming from the lower portion? And then as a result of evolution of both the surgical technology and the endoscopic technology, when we talk about small bowel neoplasia or small bowel bleeding, occult gastrointestinal bleeding, we now have a marriage of these two fields coming together and really creating a unique symbiosis where the gastroenterologists, such as Dr. Cave and myself, can work together and really bring a cure to patients who previously were unable to have their problem solved.
You know, so I think by nature gastroenterologists tend to be collegial, but I think this is a particularly special group that works really well together. We have Dr. Cave, who's a renowned expert in video capsule endoscopy, and he has a number of protocols regarding GI bleeding that will ultimately result in publications and hopefully change the way we practice. Going forward, we have to become cutting edge in terms of managing our resources, in terms of utilization and quality. And that's a big push within the country, but certainly within our GI division. And so we have several activities where we are sort of measuring our quality metrics as well as our utilization of endoscopic resources, and I think that will position us well in the future.
One of the things that I have said over many years is that as gastroenterologists we were very predictable. Our mission was very clear. That's changed dramatically over the last several years. I think that the way that we provide health care in the United States is changing, and I think that if we want to be at the cutting edge of that, we need to change the way we do things.
The patient comes first, and we're always looking for new, safer, better, and often, if we can now, because of the cost of healthcare, in less expensive ways of delivering optimal healthcare.